let's get 2 minutes on the clock and your time starts now. Alright, time is up, and sometimes the exam is going to throw you these kinds of curveballs, those clinical situations that the patient walks in and your heart just sinks ever so slightly. Now, this is one of those things as well. They want to know a fellow, a consultant of the college knows how to manage. And so here, this is one of those things that you can look up. There are clinical guidelines on the RACG website and recommendations in place of how to manage these exact situations. So some of the things you would be checking for. Pardon me. Oh, always great to cough into the microphone. A+ move. With permission, with patient's permission and consent, contact their previous GP to confirm the history or the medication list. So actually ensuring that that list is up to date. Just a little clinical practice point here. Don't use the phone number on the bit of paper they provide you. Don't just Google kind of doctor name kind of thing. People are getting really elaborate in terms of the schemes and traps and tricks they use to try and do this. So if you can, actually go to APRA, put in the clinician as their name is provided, see if they actually are registered, see the location they're practicing, and only then Google their details, make sure those details match up, and try and call through for that clinic to speak to that doctor directly. Now, of course, we are lucky these days to have things like SafeScript or Dora, depending which state you're in. I know there's lots of others as well. There is the National Doctor Shopper hotline as well, which provides a similar service on a national level. But the important thing is you're checking those state-based prescription checks for previous prescriptions. This has the advantage of giving you what medications they have been prescribed, but also the frequency and often the details of who's been prescribing those things. Now, I live in a border town, so Mildura is kind of far northwest Victoria. We're kind of on tri-state between, we're in Victoria, but right up against New South Wales and a stone's throw from South Australia as well. So some of those clued-in patients know that if they jump across the border, they're not going to get flagged in SafeScript, which we use, and have that potential to be able to doctor shop that a little bit more liberally. We'll catch on to them, don't worry. Of course, you can also, in fact you should also explain that you're unable to provide these scripts today until the medication history can be confirmed. And tied into that as well, but definitely a separate response, is explain that you cannot legally provide scripts without an appropriate Schedule 8 permit being in place. So you'd be checking for those permits to be in place from the appropriate state-based authority. So again, tying into that, you should not be prescribing for this patient presenting today. You can, though, offer simple analgesia like paracetamol and ibuprofen, and it does take a particular sales pitch, particular communication techniques to be able to do that in a way that's not going to just aggravate or upset the patient. And of course, offer a follow up in 24 to 48 hours to appropriately manage the pain. Give them that time to let you do those fact checks, do those appropriate safety measures to make sure you're treating them appropriately and bring them back in. That also, I think, shows the patient that you're on their side in terms of trying to manage their symptoms, but it's making sure everyone's safe to be doing that. Now, of course, you can also provide them with the clinic policy on prescribing. In particular, this is specified it's a new patient, so most clinics will also have a new patient prescribing policy, and this can often include statements such as, "We do not provide Schedule 8 medications on first consultation," so you can reflect to, which also gives you that little bit of an out to say, look, it's actually a clinic policy, my hands are tied, I actually can't do it even if I wanted to. Again, it just helps take some of that tension out of the room and gives you that little bit of a safety net to do those other checks and hopefully put some measures in place. While you're doing all this as well, you can be examining for evidence of drug misuse or abuse. So really trying to build up, is this a patient who is genuinely seeking help and assistance? Is there potential other motives here? Being careful, of course, that sometimes those two coexist. You can have patients that have chronic pain, have chronic issues, and do use other means to try and manage their condition, and they are equally valid in needing healthcare, and in some regards even more worthy of our time and devotion to try and get things sorted for that patient. Not easy, but incredibly important work, and I tip my hat to anyone that's involved in that space. All right. Of course, we've got more questions on this topic because it's something we all love to manage, of course. So let's get 2 minutes back on the clock, and your time starts now. All right, time is up, and let's get back to those answers again, of course. Now, this is one of those times again where they're looking at those more kind of clinic, those broader aspect things of what things can you be looking out for to try and identify patients with or at risk of drug or alcohol abuse. Again, this is taken from RACGP policies, and wow, they're asking for 6. We have so many more things we can choose from. This is often one of those times where a little bit of common sense goes a long, long way, and if you just think through logically, you're going to pick out a lot of these things as well. So if you're not familiar with the exact policy, don't fret. Go back to first principles and think, okay, if I thought a patient may be at risk of drug or alcohol abuse, what kind of things do I expect to see? Flesh out your answers from there. Quickly stepping through them all. So aggressively complaining about the need for a particular medication, definite red flag, particularly if they're specifying that medication by name. even bigger red flags if they're specifying name and dose. If they're asking for non-generic medication, so again, really honing in on I want the Targin, I want the Endone, I want that particular brand there. And of course, if they're self-titrating their medication, if they're running out too early because they're having those increasing doses, or they're continually saying they want increased dosing. Of course, some patients do just have escalating analgesic requirements, and it's worth exploring, but if you're noting that it's a persisting pattern over time, there's your red flag. Now, of course, sometimes they'll come in saying, oh, I've lost my script, or my script was stolen, or, sorry, not my script, my box or my medication was stolen. And if that's happening as a pattern of activity, again, you need to be concerned. If they're claiming multiple medication allergies, now this can actually be a thing as well, so do factor that into account. Really do explore what those allergies are, because often they're adverse drug reactions, which patient education explanation can go a long way in being able to take those off the allergy lists, but perhaps have them still documented somewhere so that you don't go through that same process, prescription, adverse event again. There we go, that's what I'm trying to get to. Now, of course, some patients will also say that they become agitated, angry, aggressive when there's any kind of questioning about that. If that happens, get yourself to safety. Safety is the number one priority. De-escalate that situation as best as you can, and have some serious chats about the ongoing care of that patient. We've kind of already specified there, but inappropriate self-medicating. So if they're borrowing medications from neighbours or partners or spouses, things like that. If they're hoarding medications, so you're aware that they have a collection of medications kind of forming or stashing. If they're using medications for non-prescribed purposes, so for instance, an unfortunately common situation is people that say they're taking Panadine consistently to help them get to sleep. Try and manage whatever it is that's actually stopping them from getting to sleep, and you'll probably have much more success all around. Now, of course, a little bit tricky these days when there is such a doctor shortage, but visiting multiple doctors for drugs of dependence should definitely raise alarm bells. And this is something that things like SafeScript or the Doctor Shopper hotline has been fantastic at letting us get a better idea of. So patients that are frequently calling the practice, again, that kind of hounding for additional scripts, frequently making unchecked practice visits for early refills. We've kind of doubled up a little bit there, and I wouldn't be using both of those answers. Consistently displaying disruptive behaviours at the practice, so causing scenes. Some people have learnt if they cause a bit of a scene there, they're more likely to have people just throw something at them to make them go away. Avoid that knee-jerk reaction. Check if what you're seeing there is that red flag. Consistently calling outside of practice hours, or when a particular GP is on call who happens to maybe be a little bit more liberal with some of these controlled substances, being unwilling to consider other kind of regimes to manage their pain. Really, really handy if you do have someone that is kind of ticking some of these boxes, get them to sign a drug of dependence agreement. So this is where you can form a contract with the patient specifying the do's and don'ts of how we're going to manage their condition and their medication together. If they're refusing to do that, again, you should have that red flag there. Okay, we probably need to have further chats about this. Of course, refusing diagnostic assessment. So if they're not willing to actually investigate what the cause of the symptoms could be, they just want to have that symptom management, there may not be necessarily things underlying that are consistent with what their requirements are. And of course, being more concerned about medication than the actual medication, the actual medical problem should kind of fall into that category, but raise those flags. And displaying deteriorations at home or at work, reducing social activities, largely due to those medication side effects. So the effects of the medications are slowly destroying their life, potentially even more so than the underlying condition was. Whew, hopefully you got some of those down, at least 6. Come on, you can do it. Of course, we've got one more aspect to this question. It's the final one for tonight, guys. Rally up, get that energy level up, and let's get 2 minutes on the clock because your time starts now. All right, so the more astute of you may have noticed I hadn't actually specified how many answers to give here, and it may have been added in while the question was on the screen. Whoops. Sorry, guys. Sometimes this stuff happens, but of course we do have lots of options to be picking through here. So one of the most important things is to actually link them into a service that's going to be able to give them that support. And often it's better to be linked into one of these services than to just try and do it on your own. They're often multidisciplinary in nature, have after-hours on-call supports kind of available. So please refer to local drug and alcohol support service. If you really want to get brownie points for here, I'd be specifying for a rehabilitation program. Likewise, refer to psychologist for thought redirection or CBT. Again, I'd be specifying out there cognitive behavioural therapy, avoiding our abbreviations, of course, or counselling. So just specifying why you're doing that there, but really giving them that ability to explore what could be potentially psychological causes underneath all of the physical issues that's leading to their ongoing pain. Of course, refer to a pain specialist. This could be for medication rationalisation. There are a plethora of things there that probably needs to be simplified down to a more simple regime. And where possible as well, you could say, or I wouldn't say both, deprescribing. So being able to get rid of some of these medications as appropriate. Referral to physiotherapist for a safe exercise plan. We've specified here that there has been previous surgery, so there's likely going to be a little bit of altered anatomy, and you're going to want to make sure this patient has a way to mobilise in a way that's safe and effective for them, and fingers crossed, you can actually prevent further exacerbations through that exercise regime. And of course, organise regular reviews to monitor progress. You could specify fortnightly or monthly if you really want to get kind of brownie points there, but I think as long as you're putting in some kind of sensible time frame and acknowledging that this is a patient that's going to need that regular follow-up to really look after their care.